This is a story about a hidden cost of war, a quiet, deadly toll that is eroding the strength of a fighting force. At the same time, its nation is asking it to be stronger than ever. In recent years, Israeli soldiers have been carrying more than weapons and maps. Many have been carrying wounds that cannot be seen on a battlefield.
Those wounds have translated into a disturbing rise in self-inflicted deaths and attempts, a trend that military leaders, lawmakers, and families say is reshaping the human calculus of a prolonged conflict. Benjamin Netanyahu is the prime minister overseeing those military campaigns and the government making decisions about reserve, strategy, and the long aftermath of combat.
His leadership, the policies of the defense ministry, and the readiness of the Israel Defense Forces are now all being measured not only by conventional battlefield metrics, but by numbers that usually sit outside headline briefings, hours spent in counseling centers. The availability of mental health officers and the tally of soldiers who died by their own hand. To understand why this matters, we need to pause and picture what a modern Israeli soldier has experienced since October 2023. The multi-front war that erupted after the October 7 attacks has forced sustained mobilization, heavy combat, repeated reserve call-ups, and an unrelenting tempo of operations. For many young troops, combat exposure has been intensified by the realities of urban warfare, civilian casualties, and the collapse of safe routines. The accumulation of traumatic events, losses of friends, life and death decisions, and long stretches away from family has left deep psychological scars. Reports and official summaries have documented a rise in suicides and suicide attempts across the IDF during this period. One parliamentary review flagged the scale of the problem in stark terms. A Knesset report covering January 2024 through July 2025 recorded hundreds of suicide attempts among service members, a sharp and troubling increase compared with prior years. Those numbers are not just statistics on a page. They speak to a system under pressure and to soldiers whose distress was not always detected or treated in time. The report also noted that a meaningful share of those who later died by suicide had seen military mental health professionals shortly before their deaths. That finding raises painful questions about access to care, the adequacy of treatment, and what is possible within a system stretched by war. Military officials and health experts describe multiple overlapping causes. Combat trauma and post-traumatic stress disorder are central, but so are chronic fatigue, the psychological toll of prolonged separation, survivor's guilt, and the cascading effects of disruption to education, employment, and family life that follow repeated mobilizations. Some observers point to the stigma that still surrounds mental illness in uniformed services, a culture that can discourage young soldiers from speaking openly about their struggles or that can treat disclosure as a liability in a high-pressure operational environment. Investigations and interviews with soldiers have described instances where requests for help were minimized or discouraged by commanders, fueling further isolation. At the same time, the IDF has acknowledged the scope of the problem and has taken steps to expand mental health resources. The military reports deploying hundreds more mental health officers across active and reserve units, and in some accounts, more than 1,000 such officers have been positioned both on base and in frontline environments to provide immediate support. Commanders have been instructed to make resilience programs and treatment more available, and the Medical Corps has outlined new screening and follow-up measures to try to catch distress earlier. But officials also concede that demand has outpaced capacity and that the extraordinary pressures of wartime service create barriers to effective, consistent care. Those operational realities have a political dimension. The rise in suicides is emerging as a foreign and domestic political problem for the government. For a prime minister whose central responsibilities include sustaining military effectiveness and public confidence, a crisis of morale and mental health within the armed forces can undercut broader strategic objectives. Lawmakers from across the political spectrum have pressed for urgent reforms, and opposition figures have seized on the issue to criticize leadership and planning. Some members of parliament have demanded better transparency in casualty reporting and faster implementation of preventive programs for soldiers returning from combat. That pressure means the subject has moved beyond military briefings into the quarters of power. Families and communities feel the shock of each loss in the first person. The accounts are wrenching. Parents who watched their sons and daughters leave for duty and then received a call they never expected. Friends who say a promising comrade stopped attending check-ins, then vanished. Commanders who report that a soldier seemed fine in the moment and yet took their own life within weeks. These personal tragedies expose the limits of any system that relies on brief screenings or periodic check-ins for a population living under prolonged stress. They also illuminate how the human cost of conflict can ripple outward, weakening units, eroding morale, and deepening public unease. Mental health professionals who work inside and outside the military emphasize the importance of early intervention, continuity of care, and removing the stigma that discourages help seeking. For soldiers in active operations, practical obstacles such as erratic schedules, limited privacy, and a chain of command culture can all impede honest disclosure. Experts call for solutions that go beyond more clinics, routine confidential check-ins, stronger community and family outreach, better transition services for reservists and veterans, and specific clinical pathways for those at acute risk. There are also questions about how the military and political leadership frame this crisis to the public. A government that emphasizes resilience and victory in the field must also show it is prepared to confront the less visible effects of war. When civilians measure the health of their armed forces, they watch for signs that troops are being supported both in battle and beyond it. Failure to treat and prevent self-harm undermines the basic social contract between those who fight and those they protect. It raises doubts about the long-term sustainability of extended deployments and about whether enough is being done to preserve the mental well-being of those who serve. Some critics say the problem has been compounded by a lack of full transparency. Requests for comprehensive, up-to-date suicide statistics have in some cases met with resistance or slow responses from military authorities. That lack of clarity can feed public suspicion that institutional inertia is preventing more aggressive preventive measures. Lawmakers, families, and advocacy groups have pushed for clearer reporting and for systems that can more rapidly identify risk patterns across units, specialties, and demographic groups. At the same time, officials from the military and defense establishment insist they have expanded mental health capacities and are prioritizing reforms. They point to new training modules for commanders, increased access to counseling, and the mobilization of reserve mental health professionals to reach units in the field. Military spokespeople stress that mental health care is now treated as operationally essential, a necessary component of readiness. Beyond the Army itself, communities are stepping in. Nonprofit organizations, veteran groups, and grassroots networks are working to expand helplines, peer support programs, and family outreach. Some initiatives focus on young soldiers whose compulsory service has been interrupted or extended. Others concentrate on reservists who return repeatedly from combat into civilian jobs and family responsibilities, often without a structured path to recovery. International observers and allied militaries are watching closely. Modern armed forces increasingly recognize that the long-term effects of combat on mental health are as important to national security as traditional military readiness. Lessons from other militaries underline the value of sustained investment in prevention, normalization of care, and structured post-deployment recovery systems. What meaningful progress would look like includes several pillars: routine confidential screenings tied to real clinical follow-up, a strong network of mental health professionals embedded within units, clear pathways for reservists to access uninterrupted treatment, leadership training to reduce stigma, and transparent public reporting to track progress. For Prime Minister Netanyahu and his government, the crisis poses both an operational and moral test. Military strength depends not only on equipment and strategy, but on the human foundation behind it: trained, supported, and psychologically resilient troops. The rise in suicides and suicide attempts signals that this system needs urgent reinforcement. This is not a story that ends with a single reform or a single policy change. It is a long arc written in hospitals, counseling centers, homes, and government offices. It will be measured in lives preserved, in families supported, and in the dignity afforded to those who carry the heaviest burdens of conflict. The effectiveness of any military cannot be measured solely by territory gained or lost. It must also be judged by how it treats its own in the deepest hours of need. For Israel today, the human cost is a painful reminder that endurance in war is not only about surviving battles, it is also about surviving what war leaves behind.